Naveed. I'm a neonatal consultant at KIMS Cuddles Hospital in Kurnool. I'm also the IAP Neonatal Fellowship Coordinator at KIMS Kurnool Hospital. Today's topic is about basic views of a neonatal echocardiogram. So first of all, what is the aim? Like, why do we need to do echo in an NICU unit, or what is the purpose? Why we need to learn to do an echo? The first and foremost is we screen the babies for critical congenital heart diseases. When there's a clinical suspicion, we do an echo to rule in or rule out any critical congenital heart disease, and also mainly to establish structural normality of the heart. If there's any concern with structural normality, we obviously have to contact a pediatric cardiologist. The second foremost important thing is to diagnose and manage the common neonatal problems that we see in an ICU setup, like persistent pulmonary hypertension, to diagnose and manage and monitor PDA, and last but not least, the functional assessment of the heart, like assessing the volume status, calculation of cardiac output, and determination of ejection fraction in neonates with shock. So before we start, let us get a brief idea about the orientation and basic anatomy of the heart. As we all know, heart is not situated straight down from top to bottom. It is in an angulated fashion from 11 o'clock to 5 o'clock position. If you imagine a clock, it is positioned, the long axis of the heart is positioned from 11 o'clock to 5 o'clock position. Okay, so it is not straight. And the right-handed structures of the heart are anterior, while the left-handed structures are posterior. Okay, it is not like AP position of the heart. It's angulated so that the right-handed structures are anterior, while the left-handed structures are posterior. Atria lie to the right of their respective ventricles. This implies the ventricles are to the left and inferior of the aorta. So in this anatomy, the left atrium is the posteriormost chamber of the heart. So regarding the cardiac walls, again, they are not all arranged side by side. They are arranged in different planes. The aortic wall is central in position, and all the walls are surrounding the aortic wall. The pulmonary wall lies anterior and superior to the aortic wall, as you can see in the picture. As you can see in the picture here, it's anterior and superior to the aortic valve. And both the AV walls flank the inferior margins of the aorta. Okay, aortic valve. And tricuspid valve is the inferior-most valve when it is closer to the cardiac apex compared to the mitral valve. So the two AV valves are not lying side by side. A tricuspid valve is inferior and closer to the apex compared to the mitral valve. That helps us in differentiating the tricuspid valve from mitral valve. So, as I mentioned in the previous slide, regarding the tricuspid valve, it is more apical, and it is attached or supported by the interventricular septum. It is not in continuity with the outlet valve, that is not in continuity with the pulmonary valve. On the contrary, mitral valve is slightly higher up. It is not attached to the interventricular septum, but it is in fibrous continuity with the outlet valve, that is the aortic valve. And it is supported by two groups of papillary muscles. It is very important to differentiate which is tricuspid valve and mitral valve, because as we know, the AV valve goes with the ventricle. So whichever side is the tricuspid valve located, that ventricle is right ventricle. Wherever you decide, or we decide on scan that it is a mitral valve, that side is the left ventricle of the heart. Regarding the cardiac chambers, the right ventricle is associated with tricuspid valve, as we mentioned in the previous slide. The cavity is triangular in outline with coarse trabeculations and moderator bands, while left ventricle is ellipsoidal with fine trabeculations and papillary muscles. So it's important to know where your right and left ventricles are. That helps us to decide whether there is AV concordance or not. Regarding the outlet valves, the pulmonary outlet tract swings to the left and is superior to the aortic valve. As I was showing in the slides before, the aortic valve is anterior and superior to the aortic valve. So the pulmonary outlet tract also swings to the left and is superior to the aortic valve. That is how the crossing over of the major arteries happens. So it crosses over uh, pulmonary or right ventricular outflow tract, crosses to the left side, and it crosses the aortic valve. Okay, na? So next is the slide is about 1 or 2 slides about the Dopplers, because that's the important part of our examination as well. So the red color indicates that the blood is flowing towards our probe. So R for R, towards red. The blood flowing away from our probe appears blue. And when you do the Doppler here, the waveform, the positive above zero, this is the zero line. Above zero is the blood that is flowing towards our probe. The blood flowing away plots as a negative graph. So the blood flowing towards appears red. The blood flowing away from our probe appears blue. Then we also measure the velocity of the blood flow. We can measure up to 7 meters per second velocities with our Doppler machines, with our echo machines. And then by using the Bernoulli's equation, we calculate the gradient across the wall, whether it is a ventricular septal defect or PDA or tricuspid leakage, whatever velocity that we get, that velocity is squared and then multiplied by 4 to get the gradient across the wall or the septal defect. Now there are 2 forms of wave Dopplers. One is the pulsed wave Doppler. The other is the continuous wave Doppler. The pulsed wave Doppler can measure velocities up to 1.5 or up to 2 meters per second. It looks at the small area and at a particular depth. So it accurately locates the position of the abnormal blood flow in pattern. So wherever you want to measure the velocity, you take our cursor there and then measure the exact velocity there. That's how the pulse wave Doppler helps. It gives the accurate assessment and a particular depth. So at this position, this is the velocity of the blood flow. But it cannot measure the higher velocities, which are above 2 meters per second. For such blood flows, or turbulent blood flows, we will need continuous wave Doppler. So when the flow velocities are more than 2 meters per second, we use continuous wave Doppler. It accurately assesses the maximum velocity of the flow in question, but it lacks the selectivity and depth recognition. So usually used for high flow dynamics, like when you're measuring a PDA flows or in PBHN, measuring a TR flow, TR jet flow. That's when you use your continuous wave Dopplers. So the flows can be broadly classified again into laminar flows and turbulent flows. Laminar flow indicates that the blood flow is smooth and laminar. So all the blood plot is along that narrow graph, right? So this is the laminar flow. There is a central hollowing in that. Okay. When you take rapid turbulent flows, it appears like this, right? With a lot of plot in between. So this is all like a shaded area. This indicates that there is a lot of turbulence. This is a turbulent flow, and this is the laminar flow. This indicates high flow velocities or narrow valve or defect. Then the next thing about the different types of views. So we always should use segmental approach. Do not have a specific pattern that you normally examine, and always follow that pattern when you are doing any echo, right? Normal anatomy should never be assumed. Remember that point. It's very important. Normal anatomy should never be assumed. It should be proven. If you can't find it, assume that there is something wrong. Don't assume things that it might be there or it is normal, but I'm not able to pick it up. Don't have such assumptions. So first and foremost, establish the situs, okay, that it is a levocardia. So only after establish situs, it makes it much easier to check for other anomalies. Like if it's a dextrocardia and you're trying to do the echo, it will cause a lot of confusion. So first establish that it is levocardia. Then we know atrial concordance, atrioventricular concordance, then assess the ventricles, then ventricular arterial concordance and arterial crossover. That should be your approach. Well, at least this is what I use. Everyone can have their own way of doing the echo, but this makes it easier for me to understand the anatomy and the structure. Then we can assess the arch and then the descending aorta. If there is an duct of it's a preterm baby, if there's an duct, you assess the duct and its hemodynamic significance. And then you can assess your pulmonary veins that are draining into the atria and functional assessment of the heart like cardiac output and functional shock. Next. So different views I have put on one slide. So first and foremost, I generally start with subcostal views. This helps me to establish the situs. So the probe is positioned here to establish the subcostal view. Then you can do your apical view from here, and then the parasternal long axis and the parasternal short axis. We should imagine the body of the baby in the form of a clock, right? So this indicates at 3 o'clock, this indicates 12 o'clock, this indicates 3 o'clock, and this is 6 o'clock position, right? So we use this as a 3 o'clock position, which will be needed for apical 4-chamber view. This is the 1 o'clock position, and this is the 11 o'clock position. So imagine the human or a baby as a clock, and based on those clock hours, it is easier to do the echo. It helps us to get good landmarks, right? So parasternal long axis and short axis, also called as low parasternal views, and then you have a high parasternal view or the ductal view, and then the suprasternal view, right? In the subcostal view, as I said, first have your probe positioned in the 3 o'clock position. So the pointer and the probe that we use should be positioned in the 3 o'clock position, right? And then angle the probe directly downwards, straight down, and the pointer towards the 3 o'clock position. Then what you can see is the image like this. This shows your vertebra and a pulsating vessel slightly to the left of the vertebra, and that is the aorta, right? There's a UAC institute, and then towards the right you will see an IVC, which is not as pulsatile as the aorta, might be slightly collapsed, and then this structure is the liver, right? You can even assess if the vessels are flowing or the blood flow in the liver is okay. In conditions like intracardiac TAPVC, you might see dilated hepatic veins, right? So just if you keep glancing or keeping an eye on the vasculature there on a regular basis, you will know when it is abnormal, right? Help us differentiate what is normal from abnormal. So in this position, this is the vertebra, this is the aorta, this is the IVC, and this is the liver, right? So this is in the 3 o'clock position, looking straight downwards, the probe pointing directly downwards. This is the nomenclature. Then from that 3 o'clock position, turn the probe pointer towards the 12 o'clock position, so towards the head, right? So the probe pointer is kept turn about 90 degrees to make it 12 o'clock position. Then you can tilt slightly to the right, you'll see the IVC. Then you tilt slightly to the left, you will see your aorta. So when you are tilting to the right, what we see is this IVC in the longitudinal section. This is the IVC. So you can assess the volume status of the baby if the IVC is dilated or collapsed. Helps us to know the fluid status of the patient, right? So this is the IVC. Then you assess that the IVC is opening into the RA or the right atrium, right? The major vein, one major vein opening into the RA. Then so this is without the names, this is the IVC that you can see opening into the right atrium. Then when you tilt to the left, you will see the aorta. Aorta is more closer to the vertebra. This is the vertebra and this is the aorta. This is without, once you switch on the color Doppler, this is how you can see the blood flowing. And this is our pointer position. The blood is flowing from the aorta into the celiac and the superior mesenteric artery. That is why it will appear red, because it's approaching towards our probe, right? So you can even do the Doppler like it is shown below here. This is the positive flow in both systole and diastole. the one below here, it's absent flow, and this is the reversal flow. The flows in SMA or celiac are useful when you are assessing the hemodynamic significance of a PDA. If there's a reversal, it indicates your diastolic steal, which shows that the PDA is hemodynamically very significant. Right. So after we assess our IVC and the aorta in your 12 o'clock position, then turn back your probe pointer towards the 5 o'clock position. Again, if this is the clock, this is somewhere the 5 o'clock is, right? You position your probe somewhere in this angle, right? Pointing in the 5 o'clock position, and then tilt your probe slightly above so that you can assess your heart. You are in a subcostal position. You are trying to see the heart from below, and this is the interatrial septum that you can see, right? So if there is any defect in the interatrial septum, this is the only view where you can assess, right? And when you switch on the color Doppler, the blood flowing from the left atrium to the right atrium, it appears red because our pointer is below. Here we are looking up towards the heart from below. Any blood approaching from left atrium to the right atrium will appear red. Okay, so that is normal physiology. The blood flowing from LA to RA. In conditions like very severe PPHN or TAPVC, you will see total blood flow appearing as blue. Okay, indicates there is no pulmonary vein draining into the LA and the whole blood is shunting from RA to LA. That is why it appears completely blue. Even in PPHN, there will be some bidirectional flow, but only in TAPVC you will see that the blood flow is completely blue. For the beginners, for all practical purposes, this should mean that, or you should suspect or high risk of TAPVC and call your seniors to look at this baby. You can also, in this similar view, the same view, you can also assess your blood flowing. This is where your SVC will be. The blood flowing from SVC, it will appear red in color. If you want to measure SVC flows, this is also the view from where you can measure. Then from this position, if you tilt slightly anteriorly, you will see the two ventricles, right? And then if you tilt more anterior, you will see the aorta coming out or LVOT coming out of the left ventricle. And then tilting more anteriorly, you will see the right ventricular outflow tract coming out. So you'll get a brief idea about the whole heart in this subcostal view. You have established your situs, you have established your LA, RA, the blood flow across the PFO, and then you have get an idea about the two ventricles with its interventricular septum and left ventricular and right ventricular outflow tracts. Okay. After that, you move on to the apical four-chamber view. Right. So the probe position, again, look for the apex, where the apex of the baby is. It can vary from baby to baby. So find a good position where you can see that the heart is appearing straight or erect type on your scan machine, right? And the probe pointer should be in the 3 o'clock position in this. So in the 3 o'clock position, find the apex, pointer to the 3 o'clock position, flip the position on the screen. Majority of the neonatal consultants prefer to do it this way. The adult cardiologists generally do inverted heart in the four-chamber view, but we prefer to do in the normal anatomical position. So the probe is placed in the 3 o'clock position, and then this is what you will see when the probe is kept exactly over the apex. And this is where our probe pointer is. Here, first get an idea of how the four chambers are. So this is the LA, this is the LV, RA, RV, the two AV valves, right? The two AV valves, the mitral valve, because and this is the tricuspid valve. This is called tricuspid valve because it is more closer to the apex, also called the offsetting of the AV valves. So AV valve is more closer to the apex. It is attached to the interventricular septum, and it is not in fibrous continuity with the outlet valve, right? So we established that way that this is the tricuspid valve and this becomes the right ventricle. So then switch on your Dopplers, blood flow Dopplers, then assess the flow across the mitral valve, flow across the tricuspid valve. Any inflow will appear as red, and any regurgitant flow, that is mitral regurgitation or tricuspid regurgitation, will appear blue here. Will appear as a blue jet here. Right? You can also assess the interventricular septum to see if there is any interventricular septal defects. Right? And then when you tilt the probe a little bit, you will see that the aorta is opening up in the gap here, which will be called as the fifth chamber or the 5-chamber view of the heart. Then we'll notice that the LVOT has to grow this way, and then the RVOT appears when we tilt more anteriorly, and it goes from the right side of the heart to the left. Right, so that is the crossover of the two major vessels to rule out your TGA. Okay. And then we can also see pulmonary vessels draining. Sometimes you might be able to see pulmonary veins draining into the LA. The same image shown here. So you're assessing all the 4 chambers, inflow across the AV valves, outflow tracts can be assessed, interatrial septum can be assessed, then your contractility of the heart, fractional shortening and all can be done. Ejection fraction can be checked. This is a 5-chamber view. So the 4 chambers, 2 atria, 2 ventricles, and 5th chamber is the aorta. Then we go on to the parasternal views. So there's a long axis view and the short axis. It's also called the low parasternal views. And then there is a high parasternal view. The low parasternal views, the long axis view, the probe pointer is positioned in the 11 o'clock position. And because our heart is in the 11 to 5 o'clock position, so the long axis of the heart appears in this angle. So the probe pointer should point towards the 11 o'clock position. Right, to the left of the sternum, and in the second or third intercostal space, depending upon the baby size and baby's anatomy, there will be slight variation. In the second or third intercostal space, in whichever position you get the best view, you can choose it. And this is the image you get. Right? This is the left atrium, the mitral valve, then the left ventricle, then the outlet of the left ventricle, that is the aorta. Then the AV valve will appear here. So this is the mitral valve, AV valve, and this is the right ventricle and left ventricle. You won't be able to see the right atrium in this view. Okay. So here we assess the ventricular septum. So we assess the ventricular septum. So we can switch on the color Doppler and see if there is any septal defect here. Mainly the membranous part of the septum or membranous VSDs and all can be seen where get a better image of those septal defects in this view. So you assess your interventricular septum, and then we do the lower tilt or the upper tilt. That is, from that position, you tilt downwards, looking into the right ventricle. That is why you will see the inflow of the right ventricle. And if there is any tricuspid regurgitation, that can be assessed. So the down tilt to look for any TR in the tricuspid valve assessment. Then when you tilt upwards, you will see the outflow tract of the right ventricle. So the right ventricle inflow and outflow can be assessed by tilt or sweep of your probe down and up. Then if you do the upper tilt, you will assess the main pulmonary artery. You can also assess your pulmonary valve. Then we change into M mode. In the M mode, you can do your calculations of LA-AO ratio to assess hemodynamically significant PDA. You can calculate ejection fraction and fractional shortening to assess the myocardial function, which you can go in the next step. So here I'm not covering that because we are doing just the basic views of the heart, but this is the view for us to do LA-AO ratio. Then we move on to the parasternal short axis view. We turn the probe to 90 degrees, that is, you get into 1 o'clock position, the probe pointing the 1 o'clock position. And this is what we see. So the aorta is in the middle, and the whole heart is wrapped around the aorta. That's how the structure is. The aorta is in the middle. It's also called as the Mercedes-Benz sign because of the three leaflets of the aorta appear this way, like a Mercedes-Benz sign. So this is the Mercedes-Benz sign of the aorta. If there are only two valves, we call it as a bicuspid aortic valve. So the middle is aorta. This is the left atrium, interatrial septum, right atrium, the tricuspid valves are here, and this is the right ventricle. You won't be able to see the left ventricle in this because here the aorta is covering up, right? This is LA, then RA, RV, and aorta. Then the opening of the right ventricle can be seen here. So pulmonary valves and the main pulmonary artery. Right? So because it's a short axis cut, the first cut in the beginning shows our aorta with the whole heart wrapped around it. And you can also see coronaries coming out of the aorta in this view. Right? Then we start doing multiple cuts along the heart until we reach the apex. The apex, as we know, is formed by the left ventricle. So the next view would appear like this, where you can see that this is the mitral valve. So when the video is on, this will appear like a fish mouth, opening and closing of the mitral valve. This is the left ventricle, and this is the interventricular septum, and this is the right ventricle. In a normal heart, this is how it should be. The interventricular septum should be bulged into the right ventricle. When the pulmonary pressures are higher, there is flattening of the interventricular septum, and the LV becomes D-shaped. Now it is round, right? So when the pressures are higher, it either becomes D-shaped, or when the pressures are much higher or suprasystemic, you might even see a crescented type of LV. Okay, we can also switch on the color Doppler to see if there is any flow across the interventricular septum. Okay, to assess any VSDs. So we have to assess for VSDs in multiple ways to make sure there is no defect in the interventricular septum. Right, so this is one cut. Then further down, you might see this. So these are papillary muscles of the left ventricle, interventricular septum, and the right ventricle. So again, LV interventricular septum is bulging into the RV. If this is flattened or bulging into LV, it indicates higher pulmonary pressures. So that's all about the short axis cut. So you assessed your in the short axis, you have one cut at the aortic valve level, next to the mitral valve level, and then lower down at the papillary muscles. Right? Now you move on to the suprasternal view or the arch view. Here you can either the pro position is the 12 o'clock position. You either go into the suprasternal notch, or sometimes if you are not able to do it here, you can even choose the infraclavicular position on the right side. This is the arch view. Here you can see that this is the right pulmonary artery, and this is the arch of aorta. This is the ascending aorta, and this is the descending aorta, and these are the branches, the innominate left carotid and the subclavian branches of the aorta. If you see any, then you switch on the color to the blood should appear red here, red up to here, because the blood is approaching your pointer, which is positioned here. We are looking from here. So any blood coming up to here will appear red, and then the blood going away from here will appear blue. Okay, this way. So by eyeballing, we can just see if there is any narrowing across the aortic arch. So if you see any narrowing, like you can see here, this is slightly narrower compared to this part of the aorta. When you switch on the color Doppler, you will see turbulence. So here the approaching blood is appearing red in this part, and then as it curves around, it becomes blue. And because here there is narrowing, the blood appears to be turbulent flow. So you can see orange, red colors, which indicates there is a increased turbulence. Right? When you switch on the flow Doppler, this would appear. This is the view that you get. Indicates that its blood flow in systole is very rapid, while then the gradual emptying showing as the diastolic tail. What we say in the diastolic phase, it is not emptying rapidly, but it it is tailing slowly. So it is not fully emptying rapidly. There is slow emptying of the aorta. So this is called diastolic tailing. This indicates that there is some coarctation or narrowing in the aorta. So one, eyeballing, then with the color you see the turbulence, then with this flow you can see that there is diastolic tailing across that turbulent part. Then you move on to the high parasternal view or the ductal view. Here you position the probe in the upper third in the left edge of the sternum, in the second or third intercostal space on the left side of the baby. And then the probe pointer should be around 12 o'clock position, that is pointing towards the head. Right? In the short axis cut, we said it will be in the 1 o'clock position, parasternal short axis. So you go one space higher and pointer in the 12 o'clock position. So make it straighter. Then you will see your duct or PDA. So normally what do we do? I won't go into depth because it's a big topic on its own. I'll just show you what the basic views should be. Right? We assess the size of the PDA, right? Just the measurement of the PDA. Then you do the color Doppler to see the flow pattern. That is how it is shunting. There's a red flow or a blue flow, or whether there's a turbulent flow, all such things. Then put your continuous wave pattern to assess the flow. In the M mode, you would see LA-O ratio, as I mentioned, in the parasternal long axis view. Then in the descending aorta, you can look for any diastolic steal. That is how you would decide if the PDA is hemodynamically significant. So images in the high parasternal view, that is the probe positioned in the second intercostal space on the left side of the sternum, pointer in the 12 o'clock position. This is what you will see. This is the main pulmonary artery. This is the right pulmonary. This is the left pulmonary. And this is the PDA. Right? This is the PDA. Pointer conpisada. So this is the PDA. So then when you switch on the color, this is how you would see. The flow will appear red generally because the blood is shunting from the aorta into the main pulmonary artery. Because we're looking from here, the blood approaching towards our probe, that is from the aorta to the main pulmonary artery, would appear red. Right? If you see blue flow, that means the main pulmonary artery is shunting into the aorta. Might indicate duct-dependent left-sided circulation or very severe pulmonary pressures, when the shunt will appear blue. In normal PDA, generally the shunting is from the aorta into the main pulmonary artery, so it will appear red. Depending upon the turbulence, you might see different colors. The smooth flow will appear red. If there is turbulence, you might see slightly orange or yellowish colors. And more bidirectional shunting might appear blue when the blood is shunting from the main pulmonary to the aorta. So this is another view of so this is the main pulmonary artery, yeah, and this is the duct. So we normally measure without the color. So measure the size and then put on the color to see the flow pattern. Here it is again red flow, which means the blood is flowing into the pulmonary artery, but there is slight turbulence. That's why the color is like this instead of being plain red like here. Right? So it indicates the turbulent flow, which means the duct is probably narrow. Then you assess the flow pattern. There are 4 or 5 different patterns that you will see. So if you see, let us start with the D. This is a normal pattern where the blood is flowing from the aorta and is emptying into the duct, into the main pulmonary. So the flow is smooth. Systole goes up, diastole comes down, systole goes up, diastole comes down. This is the normal pattern, also called as the pulsatile pattern. So it appears like a pulsed flow. So number D is the pulsatile pattern. When the duct is closing down, the pressures remain high in the pulmonary artery, so the pressure doesn't come down from here. So it appears like this. It's all the wave is staying up, and this is called as the closing pattern, which is the E here. The pulsatile pattern indicates the duct is big, the shunting is happening nice and smooth. That's the pulsatile flow. Here the shunting is happening, but the pressures are not coming down, indicates the duct is slow, small, or closing down. Then here the positive flow is less, the negative flow is more. Indicates right to left shunting. It can happen in severe PPHN or duct-dependent systemic circulations where most of the flow is happening from right to left. So this is a negative flow. Here, the B is bidirectional shunting. In majority of the PPHNs, it is bidirectional shunting. So this is the positive flow, and then this is the negative flow, which are almost similar sized. This is more, so more left-right shunting is happening, but it is bidirectional shunting, which again indicates higher pulmonary pressures. This is the growing pattern where most of the flow is left to right, like you see in the pulsatile pattern, but there is some reversal shunting. It can happen when the pulmonary pressures are slightly high in a baby who has a nice, moderate or large PDS. In the first couple of days, when the pressures are slightly higher, there will be some reversal shunting as well. This will appear as the growing pattern. So ducts like this, slowly the pulmonary pressure drops, yeah, and it will become like this in the next 1 or 2 days. So both growing pattern and the pulsatile pattern is where we need to treat. The other patterns like closing pattern, pulmonary hypertension patterns, we generally don't treat. They are not advisable to treat. Then the last one, to assess the pulmonary veins, we have what we call the crab wave. It's a parasternal short axis wave, right? That is in the parasternal short axis wave, which is 1 o'clock position. You move slightly 1 or 2 spaces higher, yeah, and then angle your probe inferiorly. That means you will open up your left atrium, and in that way you can assess the pulmonary veins flowing into the left atrium. To assess your pulmonary veins, you might have to drop your Doppler flows to lesser velocities so that you can assess the venous flow. This is the view that you get. So this is the LA that you have opened up, and you will see that this is the right upper pulmonary vein, right lower pulmonary vein, left lower pulmonary vein, and the right upper pulmonary vein. So you might not be able to see all of them, but at least if you can pick up 2 veins flowing into the LA, your TAPVC is ruled out. So with the color on, this is how it will appear. The blue color hasn't come out that well, but this is the blue flow, and these two are your red flows. The 2 flows up, yeah. So the 4 pulmonary veins opening into the left atrium. So come to the end of the presentation. So we need to have, like I said, segmental approach. First, assess your veins, like your IVC and your SVC. Make sure they're opening into the atria. Then atrioventricular concordance. Then assess your ventricular chambers. Then arterial crossover, arterial concordance and crossover. So have that segmental approach, or you can have your own way how you approach. But this is what I follow. Then that helps to establish your normal anatomy. Now always document what you see and don't assume things. If you can't find it, document that such thing could not be visualized, right? So normal anatomy should never be assumed. It should be proven. And any abnormal finding that you find, ask your cardiologist to review the scan. Right? These are the few books that you can read. It'll be quite helpful. The top one, Point of Care Neonatal Ultrasound by our Pradeep Suryavanshi sir, and another book, Echocardiography for Neonatologist by Jonathan Skinner. Any questions you can pin down in the comments. Thank you.